Good morning. Welcome to the Master Plan for Aging Webinar Wednesday. I'm Kim McCoy-Wade, Director of the California Department of Aging and convener of all things Master Plan with our Health and Human Services Agency. I'm so glad to see the numbers climbing. We're already over 50 people who have joined us, so welcome. And it keeps climbing. Welcome to Webinar Wednesday. Today is a very special topic that we have been eager to turn to since we have heard it in so many forums from so many of you. Isolation, inclusion, and respect. This is one part of our examination of the social environment, of how we truly build a California for all across the lifespan. We're listening and learning through this forum called the Webinar Wednesdays. We have been doing this every Wednesday, starting in January through April, from 9:30 to 11. You can always find the information about them at engageca.org, our website in English, Spanish, and Chinese. No registration necessary, lots of live polling. It is meant to be a conversation and a dialogue, and all materials are posted after the webinar so you can look or listen and send to all your friends and family. As part of hearing from you, there will be polls running throughout the presentation. We want to know who's here, we want to know what your experience has been, and we want to know your recommendations for the master plan. While I'm doing the opening remarks about the master plan and our topic today, you'll see a few polls start to run as we figure out who is with us today. So thank you in advance for answering polls as you are interested and able. As I mentioned, we have a series of these webinars. I want to call your attention particularly to livable communities and purpose where we are today. You see we have a series focused on both the built environment and the social environment. The built environment, we've been talking about housing and transportation, and parks is coming right up. Very excited about that. And this is our first conversation about the social environment, isolation, inclusion, and respect. We'll be turning soon to civic and social engagement with a real focus on volunteerism. And we'll be concluding the series with the essential topic of leadership by and with older adults and people with disabilities. I urge you to tune in. So today we are delighted to have such a wonderful panel. As always, we strive to include a representative from our Stakeholder Advisory Committee member with particular expertise, a state partner here with us at state government, and a local leader really blazing the trail. We have Dr. Leandra Clark-Harvey, Director of Policy and Legislative Affairs for the California Council of Community Behavioral Health Agencies as our SAC member. Dr. John Connolly, Deputy Secretary for Behavioral Health at our California Health and Human Services Agency, and my colleague. And Mike McConnell, one of the first people I met when I became Director of Aging and visited with Santa Cruz County and got to see what you're going to see today. Mike is our Adult Services Division Director in Santa Cruz County. Please keep your eye out for the polls. So the Master Plan for Aging, a quick tour of how we got where we are and where we are. This began in June after months and months of organizing and advocacy and education. Governor Newsom was honored to issue an executive order in June calling for a master plan, recognizing that the big changes in our state and the big opportunities and challenges that come with more of us aging. To convene both a stakeholder advisory group and a cabinet work group to issue a 10-year master plan by October 2020, with a real focus on long-term services and supports, the help we all need to live in the homes of our choice, and a research subcommittee to be sure we're data-driven. Why is this so important? Not just only that there's more of us aging, but that aging is changing in really interesting and important ways. More diversity, more of us living alone, more of us at risk of poverty, and more awareness of the stages of aging. As longevity has lengthened, more awareness that 50 and 60 and 70 and 80 and 90 and 100 can all be very different chapters of our lives. So just again, to be data-driven, look at that growth in our older adult population, that orange box for those of you who can see it. In 2010, about 38%, in 2010, we have 4.3 million older adults, and by 2060, that triples, doubles by about 2030. So we are growing. And significantly, whose aging is changing. In 2010, about 38.1% were people of color, and by 2060, 67.1%. One way to look at it is to look at the box that is white, is actually the Latino group. You can see in 2010, 0.8 million, or I would call that 800,000. And by 2060, 5.5 million. The greatest growth, the fastest growth, really a diversifying, which brings so much richness and opportunity to our state. We also talked about living alone, a particularly important point for this conversation about isolation. more of us are living alone, and that can be linked to poor health outcomes. It can also have a geographic component, particularly in rural communities. And of course, we've heard a lot from our LGBT brothers and sisters about the particular issue for the older community that may have different family structures and family experiences, and making sure that a master plan for aging is relevant to all these family sizes, structures, and shapes, families of all choices and all kinds. Another way that aging is changing, despite the wonderful safety net of Social Security, is that there are increasing risk of poverty and near poverty, and that as may not be surprising to many of you, there are disparities, many disparities across gender, across place, but in this slide we can see the disparities across race. Latino, African American, and Native American, close to 40% of elders are poor or near poor, slightly less for Asian, closer to 33, and white, closer to 25, but significant rates across all races of poverty and near poverty, as well as disparities. And lastly, just a quick look how aging is changing. These are my favorite charts, these population charts that show at the bottom how many people are 0 and all the way up to 100. On the left is male, on the right is female. And you can see back in 1989, we were more of a pyramid with that bulge at 2030 for California's college campuses and military bases. But by 2019, gosh, last year, we're looking more like a pyramid with more equal numbers at 0 and 60. And if you look out to the future, more of us will be 70 and 80 and 90 and 100. And what those years look like compared to the prior decades and our experiences at each of those decades is critical to understand. We continue to change and grow as we age. So given that backdrop of the data, and of course, Governor Newsom's own personal experience with his family and friends, it really was clear that it was time for California to have a master plan for aging with a bold vision of California for all across the lifespan, and really rooted in California values: choice, equity, dignity, inclusion and accessibility, both innovation, what's new, and evidence-informed, what's been proven by the research, and as always, strong partnerships. Nothing in California happens without partnerships between local and state, public and private, government, nonprofit. It's all of us working together. So the mission we were given is a person-centered, data-driven 10-year plan by this October, and not just a state plan that sits on a shelf, but a true action plan that drives state priorities, but also helps local communities who are making plans for aging and already seeing new opportunities and new needs, whether it's on housing or transportation or many other community issues. Totally data-driven. We're working already to stand up a data dashboard for aging for October. That'll be the 1.0 version of state and local data you can use to measure your progress. And then, as always, best practice resources to learn from each other what's working and what can we replicate in our communities. We're aiming to tackle 4 goals that we think are the key to a successful and happy aging. Longevity is great, but we all need help, as our daily needs may change as we age, so we need help to be able to get help to do that. We want to live in communities that welcome us and include us as we age-friendly, dementia-friendly, and disability-friendly. We want to optimize our health. We want to stay healthy, whether that's nutrition or falls or mental health that we'll be talking about today. And of course, we want to not run out of money. We want to have economic security. We need to have economic security and be safe also from abuse, neglect, exploitation, and unfortunately, disasters and emergencies that are far too common in California. Whew, given all that, one last slide. Here's the timeline. We are about to hit March. We've been listening, began in June, convened in August, and listening and analyzing all fall and winter. We're excited in March, which all of a sudden is next month, to receive from our stakeholders their recommendations on long-term services and supports. And then we'll continue working through the summer to hear all that feedback, synthesize that feedback, bring it to our cabinet work group, and be out with a plan this fall. So, as I said, it has become clear that issues of isolation and inclusion, respect, behavioral health are fundamental to the plan. I have begun saying that of all the issues we talked about, this is one of the top ones in terms of the urgency and the frequency at which it is raised. And so we also just want to say we are so delighted that we have our Stakeholder Advisory Committee expertise, our agency commitment. We also have our research subcommittee member, Dr. Janet Frank, is an expert, and I wanted to point out her longtime work in this area, as well as Dr. Catherine Keatsman, who many of you may know from the California Health Information Study, a great resource from Dr. Frank. I don't have a slide, but also just want to do a shout out to our cabinet work group partner at Veterans Affairs. It's just released their master plan for veterans homes. They too have a master plan, and behavioral health features prominently in there. So clearly behavioral health coming from all directions. When I'm out in the community, I am so excited to hear things. I was just in San Bernardino last week and learned about their AAA's leadership in behavioral health, and in particular their AgeWise program, providing in-home behavioral health and case management services to mentally ill older adults 60 and over. Case management, counseling, groups in the community, senior peer counseling, all part of that program. And then I haven't yet been to Vancouver, Washington, but also using Meals on Wheels as not just to do Meals on Wheels in the home, which of course is a critical, essential service, but also how about a Meals on Wheels cafe where people come together in more of a diner type experience and have that community. So really excited to see the innovation, and you're going to hear more about it. California is also doing great work as part of our California for All vision to combat ageism. I hope you had already heard about the great campaign in San Francisco, Never Gets Old. Really wonderful experience, never gets old. Pride never gets old. Innovation never gets old, with the faces of older San Franciscans. And partially in recognition of that work, the AAA director, Shireen McSpadden, just this week was named one of Time Magazine's 16 equality activists all across the nation, and the only one to be recognized for her work against ageism. So it's just tremendous. And here, also in California, you have the Leading Age California, Age on, Rage on, their pithy phrase and campaign, again, to challenge our stereotypes that so often do lead us to exclude older people as we age. There's a lot of research in this area, a lot of great resources in this area, and we just wanted to highlight a few as we turn to our true experts who are going to tackle really all of these pieces: the isolation, the bias, the behavioral health. And once again, we are very lucky that not only do we have great resources in California, we have great national resources from our federal partner, the Administration on Community Living and Substance Abuse and Mental Health Service Administration. Lots of toolkits and resources that we use, everything from substance abuse to emotional health to suicide with older adults. Just great resources out there. So with that very quick preview of the surface, I want to really hand the mic over to the experts, the people who will give us the deep dive in where we are and where we need to be. First up, Dr. Leandra Clark-Harvey, Director of Policy and Legislative Affairs from California Council of Community Behavioral Health Agencies. Dr. Clark-Harvey.
Well, good morning, everyone. Thank you so much for the opportunity to participate. I'm Leandra Clark-Harvey, and I'm the Director of Policy and Legislative Affairs at the California Council of Community Behavioral Health Agencies. I know that's a mouthful, so we call it CBHA. I'm a psychologist by training, and it really is my experience as a clinician that led me to advocacy on behalf of community behavioral health organizations. So we represent clinics like substance use disorder clinics and mental health clinics that provide services across the age spectrum. And an example would be in Southern California, we have Heritage Clinic that specifically provides services to older adults. And then in Northern California, we have Bonita House, which also provides services to older adults and their families. So we really believe in providing lifelong services and comprehensive services to all of the folks that our member agencies diligently provide services to. And when it comes to older adults across the nation, we know that there has been significant attention paid to older adult health, including the impact of isolation and loneliness. So on the next slide, I've outlined a number of national reports that have taken place over the years. And we end with 2020, our California Master Plan for Aging. So I'm really excited to be a part of this process and to bring that behavioral health lens to the work that's happening as part of the Master Plan. Next slide. So I start with this quote because I think it's really important to discuss this topic, because as you can see, though isolation can really be a positive coping strategy, for example, I have 2 toddlers and I love to isolate myself from them at times. Today, we really want to focus on the deleterious or negative effects of isolation and loneliness and how to combat isolation and loneliness in order to really lead a healthy life. So this quote says, as you can see, being connected is widely considered a fundamental human need. It's crucial to survival. Next slide. So there are a number of social variables that are contributing to isolation and loneliness. So as family size has shrunk and older adults are increasingly living alone, they're becoming more susceptible. And we also see that volunteerism is declining and affiliations with, for example, religious organizations that have traditionally helped foster community have decreased as well. So what is this isolation and loneliness phenomenon? Well, isolation is defined as physical separation from others, and loneliness is more of a feeling that causes distress. It's important to note that loneliness can also occur when people are surrounded by others. So on the subway, in a classroom, even when you're with your spouses and children. Loneliness is defined by people's levels of satisfaction with their connectedness or their perceived social isolation. So it's really about how you feel, not necessarily about who's around you. Next slide. And it's important to focus on various factors that can lead to feelings of loneliness, including elder abuse, which can include physical, verbal, psychological, financial, and sexual abuse, and lead to feelings of abandonment, neglect, and serious losses of dignity and respect. You know, current evidence suggests that 1 in 6 older adults experience elder abuse, and that's really outstanding and problematic. Elder abuse can lead not only to physical injuries, but also to serious, sometimes long-lasting psychological consequences. So it behooves us to pay attention to this and make sure that everyone is trained and aware of the effects and the impacts of elder abuse. Next slide. And when we talk about the health effects, we know that isolation and loneliness can lead to negative physical health effects as listed on this slide. So of note is the fact that loneliness is twice as dangerous as obesity, and that a lack of social connection really heightens the health risk as much as smoking 15 cigarettes a day or having an alcohol use disorder. That's huge. That's what a lack of social connection can do to a person. And when we look at the impact on mental health, we find that loneliness and isolation may lead to or even exacerbate anxiety, depression, and feelings of low self-esteem. Next slide. I want to take a few more minutes to continue to discuss some of the mental health impacts. So the World Health Organization actually includes mental health as part of their overall definition of health. That's important to note. And we know that among the older adult population, 20% over the age of 55 have a mental health diagnosis. Older adult men have the highest suicide rate, and older adults with depression have high utilization rates of medications and emergency rooms, as you can see here on the slide. But importantly to note, depression, for example, is treatable. 80% of depression cases are treatable. So these statistics are very bleak. There's also hope with the appropriate treatment. Next slide. It's also important to talk about dementia because we see how isolation and loneliness can be harmful to those with dementia. It's a growing chronic disease and brain disorder, and it can impact activities of daily living. In fact, it's estimated that by 2030, there will be 82 million people living with dementia. So there needs to be an investment in support services for those with dementia and their caregivers to better combat the effects of the disease and how isolation and loneliness can lead to poor outcomes for those who have dementia. Next slide, please. And I'd like to talk about cultural considerations as well, because as we talk about support, it is incumbent to recognize the specific cultural factors that can impede getting the support that combat the effects of isolation and loneliness. So there was a study conducted by the CDC that found that Hispanic and immigrant and African-American populations encounter stigma, fear of deportation if seeking support, which can lead to further isolation. And we know that men also receive less support than women per their self-report. Next slide. So I want to end with this quote. This quote really recognizes that there is no one-size-fits-all approach to combating the effects of loneliness and isolation. There has to be a variety, multi-pronged strategies, which I hope to share at the end of the presentation, the end of the webinar today. But throughout the rest of the presentation, you're going to hear about how the state is working to address this issue, as well as a local program that's taking an innovative approach to providing support to older adults to combat isolation and loneliness. When I returned, I'll share some of the comments we've received from the public regarding isolation and loneliness through the Master Plan on Aging process, and then some general recommendations for what the workforce and what community members and caregivers can do to provide critical support to older adults. Thank you.
Thank you, Dr. Clark-Harvey. The comments and chats are coming in. Let's take a second for my colleague Adam Willoughby to share the results of the poll so we know who's in this conversation today. Adam, who's here?
Great, thank you so much, Kim. So we asked a number of questions during Kim's introductory comments. The first of which, we asked, are you an interested member of the public or employed or involved in fields of aging or behavioral health? 71% of folks indicated that they are employed or involved in fields of aging. 16% indicated they are employed or involved in fields of behavioral health. And 13% of respondents indicated they're an interested member of the public. The second question we asked, what age group do you belong to? 26% of folks indicated they're between the ages of 55 and 64. 24% of respondents indicated they're between the ages of 65 and 74. And 16% of respondents indicated they're between the ages of 45 and 54. Let's see, we'll move on to the third poll that we asked. Where do you live in California? Looks like we have a tie, both coming in at 25%. Sacramento region and San Francisco Bay Area. Let's see, coming in at 15% is Los Angeles, 13% is Southern California, 10% is North Coast, and 8% is Central Coast. So thank you again very much for responding to those polls, and please be looking for additional questions as this webinar continues.
Thank you. And I want to thank all of you who've been answering the polls about your experiences and the experiences of people, older people you know. We asked, how many of you, do you or an older adult you know experience isolation? 53% said yes, 47% said no. We asked about ageism, even higher, 72% said yes on ageism, 28% said no. And on depression, 80% said yes, 20% said no. And I just want to share some of the comments that you've trusted us with. Lisa says, I visit older adults at home and many use their television for companionship. Dr. Clark-Harvey, and many people appreciated the comments you made about health impact. Elna says, I see a number of people who prefer to live alone, but don't recognize that their mental and physical abilities are negatively affected by isolation. And Lorinda adds that isolation can lead to sensory deprivation, which leads to communication and cognitive deficits, which can be successfully addressed. But again, there are these health impacts. Jessica's focusing her graduate work on loneliness in elder immigrant communities and talks about the additional obstacles, language barriers, accessing services, feeling connected socially, and recommends the master plan be sure and address this community as well, which is absolutely our intention. Interesting perspective also from Jack. Jack talks about depression among caregivers and isolation. When you're taking care of your mom, he became isolated, had to quit his job, provide 24-hour care. That isolation and depression can impact caregivers as well as elders. And finally, I want to thank Sheila for sharing that her father suffered from long-term depression and committed suicide at age 59. We are seeing higher rates of suicide among middle-aged and older men in particular. So we're so grateful for the honest and candid sharing of these stories and really eager to hear from our next two presenters and of course, back to Dr. Clark-Harvey at the end about what can be done, what local, state, policy and program, family and government interventions can make a difference. So with that, I'd like to hand it over to my colleague, Dr. Connolly, from our California Health and Human Services Agency. John.
Thank you. I'm John Connolly, Deputy Secretary for Behavioral Health at the California Health and Human Services Agency, and glad to be here as a state colleague and partner with Kim and the other panelists today. So let's move on to the next slide. Thank you. So I thought I'd start with a snapshot of behavioral health across California state departments. We have about 12 departments, well, exactly 12 departments and 6 offices within the California Health and Human Services Agency, covering a wide variety of programming. Behavioral health is suffused throughout those departments. So there are different pieces of those departments working on issues that we'll discuss today. First, at the agency level, I am the Deputy Secretary for Behavioral Health, and my role is to develop and to integrate and coordinate or align programming across the departments and offices. And so we have a brand new position that I'm in here as the Deputy Secretary for Behavioral Health to reflect the priority of the Governor NEWSOM, as well as Secretary Galley, focusing on behavioral health as really an urgent and almost crisis level issue in the state of California. Also, the Department of Healthcare Services, they have a behavioral health division, which comprises many things related to licensing and certification of mental health and substance use disorder facilities. It also covers the Medi-Cal behavioral health portfolio. So the Medi-Cal program is obviously the biggest piece of what the Department of Healthcare Services does in its programming, and a significant portion of that is behavioral health services. They also have other programming within DHCS, as the department's known, focused on other community programming funded by the Mental Health Services Act, as well as through federal block grant opportunities for mental health or substance abuse prevention and treatment. Moving on to the California Department of Public Health. They also do a great deal of work focused on surveillance, things like the opioids dashboard, convening a lot of partners in the community to ensure that we are thinking upstream about how we reduce substance use, opioid prescribing, getting law enforcement, coroners in counties, departments of behavioral health working together, community providers, prescribers, to think about this in a holistic way and in a team-based fashion. So certainly DPH is working hard on many of these issues as well from a population health and surveillance perspective. Third, the Mental Health Services Oversight and Accountability Commission is outside of the agency, but certainly a critical partner here at the state level in government, working on oversight of Prop 63, known as the Mental Health Services Act, or MHSA. Their principal role in oversight is to look at the programming, to approve innovation funding and projects at the county level. They also are in charge of putting out a lot of announcements for new funding opportunities for new innovative programming and providing technical assistance, whereas the Department of Healthcare Services, related to MHSA activity and programming, they are in charge of the financing of those programs and contracting with counties for those programs and auditing their work there at the more local level. And then finally, the California Department of State Hospitals, they have a very important role in the behavioral health infrastructure and service delivery across the state. They serve a few different groups of people. There are civil commitments, folks who are conserved through the Lantrum and Petra Short Act because of their severe mental illness, so they care for that population in their inpatient facilities throughout the state. In addition, there are a variety of forensic referrals, folks who are due to their mental illness incapable of standing trial, not guilty by reason of insanity, prisoners in our state facilities with the California Department of Rehabilitation and Corrections that are referred to the state hospital for rehabilitation, and also caring for a group of sex offenders as well, as they are being evaluated before being released from prison and re-entering the community. I want to note before we move on to the next slide, an exciting new project focused on people who are not able to stand trial because of their mental illness. The Department of State Hospitals is collaborating with counties to ensure that there are opportunities for folks in that situation or facing that situation to receive treatment and restoration in the community instead of being put in a state hospital, which is, I think, a new and innovative partnership between the state hospitals and our counties. Next slide. So one of our strategic priorities here at the agency level is to improve the lives of California's most vulnerable. And one of the groups that's explicitly called out in our listing of strategic priorities is the growing aging population. And just a few data points to kind of set the stage for some of our initiatives and to provide some context for the programming that I just described. Would be CDC data indicating that roughly 20% of people 55 years or older have a behavioral health concern. So 1 in 5 people who are 55 years or above dealing with issues that we're talking about related to mental health, depression, substance use, things of that nature. And so this is certainly not common. I'm sure many of us who have a friend, a loved one, a relative, a colleague, associate in that age group may be struggling with these concerns. Second, older men, as was mentioned earlier in the presentation, have the highest suicide rate, 4 times that of other age groups. And so certainly these issues are very primary and critical to consider when thinking through how we keep folks empowered, engaged, and preserving their choice and able to live their lives in the way that they feel is most satisfying and engaging in their years as they age. Third, depression, as we know, is associated with poor health outcomes. So many behavioral health conditions have a tremendous effect on all kinds of physical health conditions and outcomes and life expectancy. So how well we care for people in their behavioral health needs or support them in that fashion will have a tremendous impact as well on what we see in terms of their physical health and their need for health care and other services and supports. And then finally, of particular concern to us at the state level from a program and financing and planning perspective is that California doesn't score particularly well among states when we look at measures of social and emotional support among folks who are aging, life satisfaction measures self-reported by people in this age group, in addition to frequent mental health distress and also rates of current depression. So very much concerned about those findings and also signaling the urgency of what we're discussing here today. Next slide. So just a quick description of the specialty mental health services on the Medi-Cal side delivered by the Department of Healthcare Services. Just echoing some of the concerns and the need for some of the programming and interventions we're discussing today, we find that penetration and engagement rates among older adults served through the Medi-Cal program are lower when we look at specialty mental health services utilization in our county behavioral health plans relative to other age groups served in the Medi-Cal program. And that's looking at everybody who is eligible for the benefit. And so we certainly have some work to do in that respect in terms of any kind of service delivery or utilization among that age group. In addition, when looking at the level of engagement in those services of people who are able to access any mental health, specialty mental health services, and this is defined as 5 or more visits in those systems, there are lower rates of engagement at that level among people who are older adults relative to other age groups. So again, certainly many issues could be at play here. Medicare is another program that serves people, or a source of coverage that serves people who are older adults, but looking at all folks who are eligible for the benefit, I think there's certainly work to do to develop more human-centered, older adult-focused programming or service models, in addition to having, I think, savvier outreach and support models to make sure that we're meeting people where they are and reflecting some of the trends that Kim was talking about in the opening with regard to the changing dynamics of folks who are aging. Next slide. So just a quick review, given all of the things that I talked about and that others have talked about, what are some of the actions that we are taking? So one of the big kind of highlights in terms of our budget proposal and in terms of our overall programmatic priorities is the CalAIM initiative, which is shorthand for California Advancing and Innovating Medi-Cal. So contained in this is a range of different programmatic and financing reforms. And just a few on the behavioral health side of things is the integration of mental health and substance use disorder services. And this is a part of an overall transformation of the Medi-Cal program throughout the next 5 to 10 years. And what that means is that rather than having separate delivery systems and benefits and provider networks for mental health, specialty mental health services, and substance use disorder services, The idea is at the county level to merge those two, to have truly integrated delivery systems and providers of those services. We are not going to split that benefit in half, and in many cases require folks to the people we serve to go to different agencies or providers to receive those services. So to the extent that we can, we hope to integrate service delivery, treatment plans, case management, and assessment processes. In addition, the Drug Medi-Cal Organized Delivery System was a first in the nation research and demonstration program to expand and improve substance use disorder treatment through a managed care model. That was done here in California. Many states have followed in our footsteps in that respect. And as a result, many people, particularly in California, but elsewhere in the nation, since the model has been replicated, are receiving many more services in a much more timely fashion. The proposal within CalAIM is to expand and build upon the previous 5-year waiver or demonstration project. It is going to morph into what we will call SUD managed care. And more counties, since they have the option to participate or not, are joining that effort. And we are covering the vast majority of Californians who are eligible for the Medi-Cal program with that benefit. So in addition to the counties that are already doing great work and participating in that opportunity. In addition, payment reform, just very briefly, providers are very burdened with a great deal of paperwork in Medi-Cal, particularly in behavioral health systems. And the idea is to streamline, simplify, and create more opportunities for innovation through the ways that they are reimbursed and the way that they report their services. So there's a lot of enthusiasm, I think, among providers and delivery systems and at the county level about these reforms. And I think we're very proud to push them forward in partnership with the federal government. Medical necessity revisions, that's out there to really create proposals for getting services to folks in timelier ways, and also doing treatment planning and getting access to services for the people who really need them in a faster and more human-centered fashion, and in ways that don't just reflect diagnoses, but also reflect the needs and the level of acuity or severity that we're observing. Then finally, in lieu of services, though that sounds like a somewhat mysterious or clunky name, what I would say is this is really one of the key areas with regard to focusing on people who are aging in CalAIM. In lieu of services is really a term for describing new and innovative services that Medicaid, Medi-Cal has not typically paid for, but because we have realized through research and through demonstration and through innovative programs that, for example, helping folks who are aging live safely in their homes by reducing risk of falls is a way of reducing our risk of not only bad outcomes for people who are at risk of being injured in their homes, but also reducing the risk that they end up in a long-term care facility, in a hospital, have an emergency room visit. So it's really a win-win proposal and a way to increase creativity of service providers in helping people live healthier and more safely and in ways that they want to live. And then finally, enhanced care management is a way of coordinating all benefits in the Medi-Cal program through one strong case manager. And that includes primary care, specialty care, including behavioral health services, dental care, long-term services and supports. And the idea is assigning one very skilled case manager to coordinate care across all of those delivery systems. It is not, I think, appropriate for us to be placing the responsibility or the burden of coordinating all those care options or all those elements of care on the people that we serve. In addition, there are programs that or planks of the waiver to increase quality, seeking alignment among different payers, and that includes our managed care plans who have a benefit for mild to moderate mental health conditions, as well as our county behavioral health delivery systems that focus on specialty mental health and SUD treatment, substance use disorder treatment. We also seek to increase the quality of our data collection and performance measurement to provide, I think, a better dashboard at the state level in terms of how we're reporting the performance of our systems and providers, with the long-term aim of increasing value-based payment. And what that means is, instead of just paying for service delivery, we look at how well we did in terms of the quality of care and the outcomes that we're seeing. And to help counties do that work, there is a behavioral health quality incentive program that is going to provide some funding for counties to update their data reporting infrastructure. Since we're raising the bar in terms of our expectations and what we expect them to report, we also want to support counties in making those advancements. And then finally, very briefly, the Behavioral Health Task Force here at the California Health and Human Services Agency will be launching next week, a week from today on March 4th. There will very soon be an announcement of all of the participants who were selected for that. And it will be a broad, diverse group of stakeholders from different sectors, from across health and human services, from both the public and private sectors. And the idea is to create a plan, a set of strategies to address the most pressing gaps in timely access, quality deficits that we see, performance measurement, integration, not only in the broader healthcare system, but also integration of behavioral health and social services and our broader constellation of community organizations and public services. And also seeking greater funding and programmatic alignment such that we maximize and align all of our state and local dollars invested in these services, but also maximize our federal partners' investment in the innovative programming that we've described. So I think that's the conclusion of my portion of the presentation, and we'll pause there.
Thank you, Dr. Connolly, for that incredible overview of all that is happening as the administration prioritizes behavioral health across the lifespan. We did ask, have you or someone you know experienced barriers to accessing behavioral health services for depression? And perhaps no surprise to our panelists, 55% say yes. And a range of barriers were shared in the chat. Cost, Gloria says the cost of mental health services if you're not on Medi-Cal is prohibitive. TF says, you know, navigating healthcare and mental health care services, it's confusing. And John, some of your comments about coordinating care are really speak to that. I would say a very interesting comment came in from Stacy Moore from AARP. In addition to barriers with systems, it's important to consider the cultural and personal barriers that individuals face in seeking mental health support. Pull yourself up by your bootstraps mentality, or the tendency to not talk about these issues in various communities and cultures is something we all need to address and overcome. Great point. But the number one comment throughout was just the lack of services. Many people spoke to, Val said there's a shortage of psychiatrists who accept Medi-Cal. Gloria said there's a lack of providers. Deanna said virtually non-existent, and ended her remarks with, we have a long way to go. So given those barriers of cost, of navigation, of cultural and personal and access, we do have a long way to go, but there are people like Mike McConnell and the team in Santa Cruz County who are on that path and have started that path. And we are so pleased to have them here to share their story. So Mike McConnell, I will turn it over to you to hear Santa Cruz County's response, isolation in older adults. But before I do so, let me just pause for 1 second. Having heard from so many of you about the barriers and about the challenges you're facing, we are going to put in chat some resources. Of course, the immediate resource if you're experiencing a mental health crisis is to call 911, but we also want to be sure you have your contacts of your county behavioral health department. Each county has one. The contacts are listed. We just put that in the chat. So if you are feeling an immediate or even just an ongoing need and want to seek some assistance, there's the resources to get you started, and I hope that's helpful. So with that, now, Mike, I will hand it over to you to tell us the story of Santa Cruz County's response to isolation in older adults.
Thank you, Kim. And can you hear me okay?
Thank you.
And can you hear me okay?
Yes, we can. Thank you.
Okay, wonderful. I joined in a low-tech way, so I apologize. My name's Mike McConnell. I'm the Division Director for Adult Social Services in the County of Santa Cruz. And I've worked in 2 counties, Riverside County and now Santa Cruz County. And I want to talk about our local response to older adult isolation and loneliness. I also want to say how grateful I am that we're working on a master plan on aging. It's been a long time coming, and it's very exciting to see it happen. Kim, thank you so much for your leadership, for coming to our communities and seeing what we do, for visiting our exhibit here. I also want to give a shout out to Clay Kemp, who is the Executive Director of our local area agency on aging and Seniors Council and a stakeholder on the group. Some of the programs that we run here in adult services are adult protective services. We have in-home supportive services. We have veteran services. And as I mentioned, our close partner, our area agency on aging. We've also recently added long-term case management for some of our more vulnerable clients. So that includes some public health nurses and some licensed clinical social workers. We are also part of the pilot program called Home Safe, which is looking at eviction prevention and homeless issues on older adults. But being in two different local communities, isolation and loneliness for older adults is certainly one of the two biggest problems that we face in this area. I would say the second one that Dr. Leandra Clark-Harvey really touched on is also cognitive impairment. And as she explained, folks with dementia or cognitive impairment are especially at risk and can have outcomes that are more difficult. And I just mentioned that issue, and Kim, you know this, but I'm glad we're working on, streamlining behavioral health services. But it's also important, and I know the task force and the master plan is also considering how we help with cognitive impairment in older adults, including dementias and traumatic brain injury. But I will get back on point. So next slide. So I want to talk about isolation and loneliness, but from the perspective of the community, it's sometimes, just the nature of isolation, it's a hidden issue. It's not always seen in the community. But the truth is, it's in every community. Even in Santa Cruz, where people surf without hearing the theme to Jaws, where people play at the boardwalk, where people walk through the redwood forest and possibly even hug a tree, it's here. And you can see in this slide that 1 in 3 seniors report struggling with feelings of isolation and depression. 43% of our in-home supportive services recipients over 60 live alone. And older adults is our second fastest growing homeless population in Santa Cruz County. So our response to this was to figure out what is our best tool to deal with this. And even though we have some great services and programs and resources in the county, really the best tool that we have and any community has is the community itself, and specifically the people in the community. So we decided to engage the older adult and the art community to really illustrate the problem, to take it out of its hiding place and reveal it to others. Next slide. So we worked with our local Museum of Art and History, and we did a 7-month planning process, and they've helped facilitate meetings with us on a monthly basis. We had 186 seniors and aging advocates as part of that planning group. Over 100 of those were seniors themselves. And they facilitated us through a process of picking the exhibit title, coming up with our 5 big ideas, and selecting artists, and also creating action cards. And I will explain all of these. Next slide. So the exhibit title that we came up with was "We're Still Here." And most of the older adults on the group really felt like even when they are out in the community, they sometimes feel invisible. But it also reflects that the issue itself is sometimes invisible to the community. Next slide. So here are the 5 big ideas that they came up with that they wanted this art exhibit at the museum to express. So they wanted visitors to understand the diverse causes. They wanted visitors to build empathy by experiencing what loneliness and isolation might feel like for an older adult. They wanted visitors to honor and learn from the wisdom of culturally diverse seniors. They wanted visitors to build a collective vision of what a more inclusive intergenerational Santa Cruz County might look like. And they wanted visitors to take action beyond the exhibition to end isolation in our community. Next slide. So we picked some artists and exhibits. One of those that we picked was Listen to Senior Words of Wisdom by artist Wes Modes. And he somehow found a bunch of rotary phones that were placed all throughout the exhibit. And when you pick up those phones, there are voice recordings of older adults giving us their words of wisdom. Next slide. Another exhibit we had, and I will feature one of these older adults in a moment, was to have powerful portraits of 5 different older adults, and that was run by Gina Orlando. And so she took a picture of them, but she gave them cameras and taught them how to be photographers and take pictures that they felt showed how they are experiencing loneliness and isolation. Next slide. We also worked with an artist named Rye, who came up with The Game of Life. And I don't know if you remember that old board game, but it was a way to give people hands-on experience of what older adults might be facing. So you'll see in that picture that people were given 3 coins to put into 5 different slots. And those slots included typical monthly expenses that an older adult might have. So there's rent, transportation, medicine, fun, and food. And with those 3 coins, which of those areas would you put those coins in? There was also another part of his exhibit where there were some car keys hanging on a hook and some empty hooks for you to put your car keys on. And think about what happens when you either lose your driver's license or the ability to drive. Next slide. We also wanted to express it through dance and physical movement. So Sid Perlman set up rooms that you can see behind the dancers that illustrated sort of the stages of loneliness and depression. And the dancers did physical expression to demonstrate what that felt like from a more emotional level. Next slide. One of the really fun parts of it was the Pajaro Valley Quilting Association had a table there where people could create their own quilt squares. So young people and families that came through could express what they would like to see an intergenerational, more inclusive Santa Cruz look like. And the Quilting Association put all those together into quilts. Next slide. And again, we wanted people to have the opportunity to take action, not just see the exhibit, not just have those feelings, but then what can we do to make a difference in our community? So we had an action wall, and people could take these business-sized cards, which would have things like be a Meals on Wheels volunteer, or it might be, read a book to a senior. And on the back of that card was the person they could contact to be able to do that. Next slide. So one of the older adults featured at the exhibit is Tim Sinamarowski, and there's a link there to a powerful radio interview that he did talking about his experience. But Tim shares how he ended up becoming isolated and depressed. So he talks about, the loss, and Tim was a very successful dentist. So again, maybe not somebody you would expect to deal with isolation and loneliness. But with the loss of a child, with a divorce, with the diagnosis of Parkinson's, Tim ended up becoming isolated and depressed. And how he found his way back to that was by being engaged in Rock Steady, which has classes for Parkinson's patients to learn boxing and to, re-engage their physical and mental health. And Tim talks about what a wonderful experience that was. But you have to think that somebody gave Tim that idea, a person talked to him, a person encouraged him. And then when he got there, he connected with people. So again, the best tool that we have, not only in planning to take care of needs in our community, but the community and people in the community themselves is the best tool for helping to end isolation and loneliness. Next slide. So the results of the exhibit, it ran from April 2019 to January 2020. Over 52,000 people went through the exhibit. The entire population of the city of Santa Cruz, where the museum is 65,000. So you could see that a lot of people went through that. Next slide. One of the other results was that almost 7,700 action cards were taken. So this means people wanted to do something about it in the community and got engaged in the community. Next slide. And then a lot of people visited the museum and were impacted. Kim came down, and I know it impacted her. I was great to go through the exhibit with her. The head of Alexa with Amazon came through the exhibit, was very impacted by the issue, had her managers go through the exhibit, and then they came back and met with 24 older adults to get their advice on how they can use Alexa to provide and enable aging with ease and independence. Next slide. Some of the other results are that we're still having connecting events that bridge people of different ages. And you can see that at connectingcruz.com. One event that they had was called Senior Night, and Senior Night where seniors in the communities and seniors from the local high school got together and interacted and read some of their favorite stuff to each other. They're continuing work by Clay's group, the Senior Council, our area agency on aging, has had an isolation and loneliness task force that came out of a wonderful summit that they did on senior needs, and that continues. Clay's group is also helping to initiate a county-wide age-friendly initiative for us. And the great thing about this is people from other counties have come through, some of my colleagues, and this exhibit, or parts of it, will travel to other counties, and they will put their own local imprint onto that. Next slide. So in Santa Cruz, we would say that all this is pretty groovy, and having a local response is very powerful. And again, I just want to emphasize that the best tool that communities have is the community itself and the people in the community. It's not always programs and resources, though they're very, very important. If we throw all of that into the issues and begin to resolve the issues, if people don't connect with people and if people don't connect to their community, older adult isolation and loneliness will continue to be a problem. Thank you.
Thank you so much. The comments are reflecting what you already know, Mike, how moving this exhibit is, how extraordinary it is, and everybody wants it to come to their community next. And as you say, not just drop in, but the experience of the planning, the experience of the action, what grows out of it from all the connections is just so powerful. We tried a little exercise virtually. We asked people to spend their last 3 coin 3 coins, and perhaps not surprisingly, most people on this call, rent and food are the far winners. We know those are major pressures, and fun, medicine, and transportation each got a few votes as well. But it is hard to have that budget for fun when rent and food and health are so pressing. So it is the wonderful opportunity and responsibility of our Stakeholder Advisory Committee to bring all this together. The community pieces, the family pieces, the personal pieces, the system, the workforce, the healthcare. And we are very lucky to have Dr. Clark-Harvey advising us on how to do that. So Dr. Clark-Harvey, I will hand it over to you to share the recommendations that we have heard so far and that you bring from your professional expertise to our process.
Thank you. So the first slide here talks a little bit about the role of the Stakeholder Advisory Committee. I think, Kim, you're actually best to talk a bit about that. I think this is the first slide.
Sure. Happy to fill that out. Yes, Dr. Clark-Harvey is one of 34 of our stakeholders that are hearing the hundreds, and I'm getting into the low thousands of recommendations that are coming in. We've been getting them from the public website, thanks to all of you who are on engageca.org, or some of the organizations have sent very detailed policy recommendations with program and data recommendations. Again, isolation, about 15% of the public comments. It may be somewhat invisible, but is increasingly top of mind. We have our research committee who is looking at it. Again, Dr. Frank, bringing that expertise. And apologies for the acronym, we have a long-term services and support subcommittee that has been very clear in their recommendations coming to us that behavioral health is a critical part of long-term services and supports. We also have a brand new equity work group who's advising and using an equity tool to look at all recommendations to ensure they're both that our plan is relevant to all communities, connects with the assets and wisdom and resources of all communities, and addresses disparities and discrimination and bias. So they will be engaging. And then again, all of those flows of input are coming to our Stakeholder Advisory Committee this spring to integrate and synthesize and turn into recommendations to the cabinet work group and ultimately the administration. So it is a long process, and we're about halfway through it. And this is right on time to hear all of your feedback and again, merge it with the expertise and the public input. So with that, I hope, Dr. Harvey, that gives you a better introduction to share the recommendations we've heard and the recommendations you're adding.
Oh, wonderful. Thank you. So as Kim mentioned, we have received many, many comments, and it's been really heartening to hear the personal stories and to hear the recommendations that are coming from the community, because that really is the purpose of all of this work that we're doing. We really want to get a sense of what Californians think about how to combat isolation and loneliness in particular as part of this webinar. And so as you know, the other speakers were presenting and I was watching the polls and the comments, there were a lot of different things that were mentioned, a lot of stories that were shared. And so I want to start off by thanking you for being so transparent and sharing that information, because it really does help us as we work together on creating the plan to be well informed and then really make sure that we're hearing your voices. And so we wanted to spend a few minutes just talking about some of the comments that are related to isolation, loneliness, or had a mental health, substance use disorder, or behavioral health focus that have come up over the time that we've been working as a group on the plan. And in the comments today, I heard stigma mentioned a lot. And so I really wanted to call that out because, you know, we can have resources, we can have recommendations, but we also really need to pay attention to the fact that there are cultural differences on how people experience their mental well-being. And thus we have to come up with strategies that are tailored to people across different cultures and how they best can get the help that they need. So just wanted to really respond to that. So in some of the comments, what we're hearing in terms of some of the consistent themes are people are really asking for consistent and reliable services. You know, they specifically talked about the need for good transportation, talked about experiencing poverty and food and those impacts on your mental health, the importance of having screenings take place at all visits that are social services focused. So whether you're going to the physician or you're getting aid from the county or the state, having professionals that are there to be able to provide screenings and really detect if there's an issue that needs further follow-up. Some participants talked about the importance of assessing dementia during routine exams, physical health exams, and also finances, the impact that that has on someone's mental health. Grants for service providers to provide more services to older adults was a recommendation that was made. And many folks talked about aging in place, the importance of being able to stay home and age comfortably in their environment and really have the supports and services follow them where they're aging. Folks talked about building supports into those who are at home, dementia-friendly cities. So lots of talk about, urban landscape and layout and how to design cities and communities in a way that is friendly to folks that have isolation and loneliness issues and dementia in particular. There was a lot of talk about awareness campaigns, which is linked to comments made earlier during this webinar and through the chat function about stigma, really making sure that there's awareness of the issues and the impacts on older adults. Also talked about affordable social options, so providing discounts for things like yoga or Tai Chi and other activities in the community. Next slide. There were some other comments about education about aging, really beginning during primary school, and making sure that as we talk about the master plan for aging, that we're making sure that we're not just focusing on the older adult population. And I really love how Dr. Ghali talks about wanting to make sure that this is a master plan for aging, not on aging, not on a specific group, but really a lifespan approach. So we should then incorporate interventions that start in grade school, talking to people, the fact that you get older, it's a natural part of life, and that should be supported in many ways. We also heard comments about intergenerational activities and relationship building, which is, linked to cultural differences as well, really respecting the role that family and community can play in the aging process for so many different adults across different cultures. So if there are opportunities to build in, mentorship and activities that don't just affect the older adult, but also include and impact the family and the community around them, those are some of the comments that we're hearing from stakeholders. Folks talked a lot about the importance of volunteerism and being involved. And early in the presentation, I talked about the fact that volunteerism is declining. People's opportunities to participate is declining. And so really making a focus and a boost on promoting volunteerism so that services can be offered. Then there were more traditional means of getting support that people were asking about, group therapy, and then also making sure that caregiver support is there as well. So these are just, a synopsis of some of the different comments and recommendations that came from stakeholders that we are paying attention to and really hope to be able to incorporate as part of this master plan for aging process. But I also wanted to just end with some information, in terms of research, in terms of what is most recommended for different segments. Next slide. So next slide, I think I covered that already. So one of the focus areas that I wanted to share just in ending is a focus really on workforce. So I'll share with you all that my grandfather suffers from Alzheimer's and he's in a memory care facility. So I really recognize the importance of a well-trained workforce and well-trained care and how that can impact not just the person that's a part of living in a facility like that, but also the family that's supporting them. And so there was a lot of comments that were submitted through the chat function about the focus of the intersection of physical and behavioral health. And so in concert with that, I think some of the recommendations that I'll share is one, that there needs to be quality of older person-centered and integrated clinical care that's provided to the older adults in our families, in our communities. And that there also needs to be a sustainable and appropriately trained health workforce. That's so important. The folks that are seeing people or dealing with their issues need to understand very well how aging impacts mental health, impacts behavioral health, and be prepared to make referrals and provide the care that's needed. Also focus on functional abilities and strength. So much of our conversation when we talk about older adults and when we start to talk about behavioral health sometimes focuses on some of the negative statistics. But we also know that just focusing on abilities and strengths of older adults, this population, can be something that not only helps with mental health, but helps provide awareness that aging is a positive thing and should be supported in our community. Also, there needs to be early diagnosis. Far too often we see people that are diagnosed with dementia or other concerns or mental health concerns very late in the process when a lot of emergency care is needed. And so if there's training by the workforce to be able to recognize early signs and symptoms, it's recommended that that will help really defray a lot of not only the costs on the systems, but the quality of life for the older adult and the families that are supporting them. And then again, in concert with that, just being really aware of elder abuse and making sure that people are fully trained and understand how to detect that and how to treat that. Last, I'll just focus on caregivers and communities. Next slide. So this is such a critical element that oftentimes is just not focused on. When we start focusing on the individual client, we forget that there is a community and there's a family that surrounds them that needs to be well informed and very well supported. And again, in the chat function, you all talked about, as I was reading the comments, there was a lot of focus on supporting caregivers. And again, I'll share, my family supports my grandfather. And so I have a mother that lives out of state, so she is not able to help him. So my sister and I kind of do the caretaking, mostly my sister because she's in Southern California there, but we have our own other extended family members that are in our households. And so it becomes very taxing and mentally and physically and financially. So that's why the supports are needed, really a multi-pronged approach to make sure that everyone's trained, the people that are providing him care, the folks in our families that are providing him care, etc. So in terms of recommendations that the research says, there really needs to be information and long-term support to caregivers as well as the older adult family member that they're caring for. Adequate housing is important. Social support for older people and their caregivers is critical. And really the health and social programs that are targeted at vulnerable groups need to be created, need to be bolstered. So people who live alone, people that live in rural areas, and people that suffer from chronic or relapsing mental and physical illness, these are the folks that really need to be paid attention to as well, and often go overlooked, but end up suffering incredibly. Last, there really need to be, as mentioned earlier, programs set in place to prevent and deal with elder abuse. All of these things will support caregivers in the community as they hope to support the older adult as they age. So, in some, isolation and loneliness, it's real. We can see that from your comments, we see that from the research. But as I just reviewed, there are strategies that can be employed to combat the negative effects of it. And I'm really encouraged by the leadership that our state has taken in this area, as shared by John Connolly earlier. And I'm heartened by the models such as the Santa Clara exhibit that Mike McConnell talked about. I'll say in closing, aging isn't about getting old, it's really about living. And learning that you can age well will actually help you to age better. So let's start celebrating and living a truly engaged life. Thank you.
Thank you. Thank you to Dr. Clark-Harvey and to all of you who have been weighing in with your recommendations, underscoring and expanding on what she presented, of what we've heard so far and what her expertise brings to the table. We have heard from so many of you. One major area are all of the civic and social activities. People are talking about local group exercise classes that need funding. Silver Sneakers has gone away for lack of funding. Lynn mentions the importance of volunteerism. Several people mention lifelong learning and the importance of that and call out the Osher Lifelong Learning Institution. There's a caution about technology, how important it is for these social and physical engagement activities, but of course technology, Bill says, does have a role for people who are particularly homebound. The second area of focus we're hearing from people is the community itself. How do we destigmatize innovative housing solutions like home sharing? and not just destigmatize them, but support them so there's safety, works with local regulations, et cetera. It doesn't affect housing. If you redesign your house, doesn't impact your tax bill. How do we really make home sharing possible for people? And people asking about transportation solutions. Is there Uber for older folks, someone asks, in terms of helping with those mobility that can leave you at home. Mountain View is working on block level emergency lists so people know where elders and people with disabilities on their block are for power shutoffs or other emergencies. And several people are here from the Village Movement, Foster City Village, and others, where people can join and be connected to rides and social engagement and other activities. So lots happening at the community level. A real theme I'm also hearing is the need for intergenerational and starting young. One commenter talks about the Friendly Visitor volunteer program, where you can have friendly visitors from a faith community or community organization, and particularly college students. Lots of advice to start the work on ageism young with kids at school age. And another shout out for a program that apparently is no longer here from Orange County, Reconnect Around Aging, that targeted people in their 40s and 50s. Again, to destigmatize and just talk about aging across the lifespan. Another bucket of feedback that's coming in is around our systems. Every caregiver, every service provider serving an older person needs to be able to screen for behavioral health and then, of course, be able to provide referrals. So lots of interest in that and more support for workers, including direct care workers, around training around age bias that many of us can bring to the table, not even knowing it, given how ageist our culture is. And more support for the adult protective services system that often is the point of entry for a crisis around behavioral health. Similarly, in-home supportive services, our state's largest home and community-based service. How do we provide behavioral health screening and resources through that? So a lot of system recommendations. Many of you mentioned the media. How do we get realistic portrayals of aging across the lifespan, across cultures, across income into the media? And that is something actually we are thinking about. As we are in California, just like Silicon Valley is here, so is Hollywood. And how can the master plan engage with our entertainment industry to reframe aging? And again, I commend to you the San Francisco campaign to reframe aging, never gets old, as inspiring and possibly something to replicate. And then I'm really grateful to our researcher friends from UCSF who say there is also research work needed in this area. Oh, sorry, correction. Reconnect in Orange County is still active and thriving, but only for 60 plus. So the recommendation was let it serve people who are below 60. So apologies, thank you for that correction in real time. But back to the research agenda, that more research is needed to evaluate which of these programs have the impact we're seeking, how do we really focus and target and evaluate outcomes and accountability. So more research needed, and thank you to UCSF for lifting that up and calling it out. Lorinda, one of our experts who's been commenting, mentions that the Gerontological Society of America has a new online course on this for people who are in the health and helping professions to help get more connection, and links will be, resources will be shared. So the good news I would say is while we have a long path to go, this is much more front of mind for people. More resources are coming, more connections are coming at that personal, community, system, local and state level. So it is grateful to see this, and actually gives me great optimism. Let me have one more second to scan because you all are commenting at the fastest rate ever, which is wonderful. A couple more shout outs for multi-generational housing. The LGBTC Center in Los Angeles has a great model, says Krista. Karen says, what about a pool of mental health practitioners and case managers to support social services with in-house services? Public campaigns to reach the actual people. Excellent. So much there. I will thank you for all of this input. What happens with it now is it goes to our Stakeholder Advisory Committee to, again, evaluate, synthesize, refine, and translate into recommendations for our state plan, our local blueprint, our data dashboard and research agenda, and our toolkit of best practices. That will all be in work through the summer and coming this fall. I do want to just take a moment and highlight the next webinar Wednesdays, because the thing about behavioral health is it is everywhere. It is the foundation to it all. We are talking in March about abuse, neglect, and exploitation, parks and community spaces, civic and social engagement, which particularly will focus on volunteerism, and geriatric medicine and the shortages there and how to address it. All of those will include behavioral health elements because it is so central, and so many of your comments and recommendations touched on that. So I hope you will come join us again, invite your friends. And of course, if you can't be there on Wednesday at 9:30, the materials will all be posted. With that, please do keep the comments coming here and through our Engage webpage. We are so grateful for your deep and thoughtful, both heart and head leadership on this central issue to making California the place we all want to age and thrive in. This is an issue that is a big one and is a hard one. But again, I am leaving with optimism and inspiration that it is increasingly prioritized and increasingly being tackled by such great minds and great partners. So thank you to all of you for joining us today, and more to come.